Hey, this is Dr. Tosha, and I'm back with Dr. Tosha After Dark. All right, so I got one for y'all today. This is the one you all have been waiting for. This is Black Women and Infertility. This is part 2. This is what your girls want to hear. Okay, so I have Atlanta's top fertility specialist here, a great friend, and she's a cool sister to boot. She one of my super smart friends, right? And so we're gonna talk all things Black women infertility, where it comes from. Can we get in front of it? Can we test for it? How do you know where it came from? Is it you? Is it him? We're gonna bust all of that down today. So baby, if you were never ready to hear what needs to be heard, this is the show. Today is today. Buckle up. Hey, this is Dr. Tosha, and I am back with Dr. Tosha After Dark. Okay, y'all, so the last time we gave you the science of it. We gave you the official tissue of it. Now we're going to break it down. We're going to break it all the way down. It's going to be broke down, okay? So we're talking Black women and infertility. What's the jam? What's the real tea? What's tea, okay? So today, we have a good friend of mine here, like one of the smartest people I know, and just super sweet, super smart, all the nine. She is the medical director at Shady Grove Fertility. She's that girl, okay? If you do not come past my doors and say you have a fertility issue without being sent to my girl, okay? I'm not going to delay this because what I'm going to do is not engage a whole lot. I'll be engaging because y'all know me, I got to talk. But I even want to know some of the things because I want to be able to pass these things on. So I am going to be asking my girl questions, the questions that I know y'all have, and let her just roll on with it, okay? So today, our guest is Dr. Desiree McCarthy-Keith. Again, medical director at Shady Grove Fertility, and she's all around that girl. Like the accolades, we ain't got time today because they're like that, okay? So I'm going to turn it to my girl, Dr. McCarthy-Keith. How are you doing, girl?
Hi, Dr. Tasha. I'm doing well.
Well, thank you so much for being here today.
I'm happy to be here.
Girl, let me tell you, whenever I see you, it's just the energy. It's just all love. It's so warm. I appreciate you for coming and talking to us, the girls.
Thank you.
So, okay. The reason I have you, sometimes we have to be in a safe space in order to be able to say certain things. But right now, this is for us by us, okay? And we're suffering from a thing. Black women have increased rates of infertility now more than ever. Okay, and a lot of what we're seeing is, well, why did this happen and how is this happening, and is there something I can do to get in front of it? Is there something I can do to diagnose it? Like, what can I do to help myself? And I want to touch on all those things. But I'm going to let you do what you do because can't nobody do it like you, okay? So I guess the first question is, with Black women and infertility, when did, the rates start to rise? When did it really become like a thing?
So I would say that it's always been a thing in our community. And we've always known people in our family, in our neighborhood, who just weren't having children.
Yeah,
and, you always just kind of said they can't have a baby. And it was just kind of move on to the next. So I think there's always been an issue with infertility in our community. It hasn't been recognized and appreciated the way that it is now.
Okay.
So, I was just talking at work earlier today. The first baby born from in vitro was in the UK in 1978. The first baby born from IVF or in vitro fertilization in the States was in 1981. Wow. So we have been doing this for a while. The issue is that the initial early 80s campaigns, outreach, treatments, they just weren't targeted to us. And so we just weren't even a part of the conversation. We weren't seen on the flyers, the pamphlet, and it kind of penetrated even the providers. So in their psyche, this is what an infertile patient looks like. It's a middle-class white woman. So if I see a Black woman sitting in front of me who says she's having trouble, subconsciously, I don't even see her the same way as if she was a white woman sitting in front of me. Oh, she needs infertility. Let's go ahead and refer her. Black women, you're fertile, hyperfertile, you can have babies, you just keep on trying. So we were just not even a part of the conversation for so long. But we've had infertility, for as
as
long
far
as
back
everybody
as
else.
anybody.
Everybody else.
Wow, I think that's a really good point. That's because a lot of times, when we deal with the new statistics, it's kind of like, well, Black women are seeing infertility specialists double that they used to, or even double that of white women. And we start to think that our problem has increased, but it's not. So from what you're saying, it's not the problem that's increased, it's the awareness that has increased.
Yes, and it's our acceptance of fertility treatment. It's our participation for so long. We all grew up with Robin Harris talking about a test tube baby and things like that. And that's a part of our culture. And so if you, I don't want to go do that because I don't want to be joked about and have these kind of things. So we kept ourselves away from that. But now
Right.
it's more acceptable. People are more comfortable to seek treatment or to talk, even say I'm going through treatment than they used to be. So we are seeing increased utilization. But what we know is that when you look at the statistics, Black women have more infertility than white women. And we have specific factors that increase our risk for infertility. Now, one thing that we do see increasing now is that women are just waiting longer before they have their family. We go to college and career and wait to find our partner. Sometimes that takes a while. Or if we don't have a partner and we say, okay, I'm going to do this by myself, by then you might be 40-something.
Right.
And so that is a disadvantage, and we're seeing more women who are delaying. And when you look at the statistics, Black women wait longer before they seek fertility care.
Yeah.
So.
And I think a lot of that too is cultural, in the spirit of, in our culture, is looked at as science fiction.
Yes.
I think that although family members, I don't think would see it this way, but I think Black women sometimes see it as a failure. And when I say science fiction, sometimes I take a listen because I'm so sister girl. A lot of times people forget that I'm actually a doctor, right?
Yes.
And so I listen to people and listen to the generation before me in my family, and I've listened to the women say, oh, they just not mates. That's why she can't get pregnant, because they just not mates. And I've heard the males who are a generation above say, oh, you just got to put her in the book. See, she ain't pregnant because you ain't got her in the right position. You got to put her in the book. You got to get her knees back to her shoulders. And that's why she ain't pregnant. So he don't know what he's doing. We need to talk to this young man. And so none of this is actually looked at as there's really a problem. Right. It's all, that ain't your Boaz, and he don't know what he doing. And it's not really looked at as serious in our community.
Right, and it minimizes it when you say that you just don't have the right partner. It takes away from the fact that there are medical reasons why people are having trouble getting pregnant. And when you go back to not just how women feel, but men also, if you're having trouble getting pregnant, you're like, I'm not a woman. I'm not a man. What does that say about me as a person, about my masculinity, about who I am to my family and my partner, and who am I in this world if I am not able to procreate? I feel like that's what I was brought here to do. And if I'm not able to do that, does that mean I'm less than? So we shun ourselves and we hide and we don't want to talk about it. And this, we just have to remove all of that stigma and the shame and just
walk up in there and be like, boom, get me pregnant. Now.
Yes. If you had high blood pressure, you go to the doctor.
Exactly.
If you had a medical condition that's keeping you from getting pregnant, you should see the doctor.
Exactly. Now, I want to veer off course a little bit and talk about something that I'm seeing as a generalist, right? So as a generalist, I'm seeing a lot of women having difficulty getting pregnant, but it's not female infertility. It's male infertility.
Say that. Yes.
As a culture, even as Black women, that's something that we don't really want to accept.
Yes.
You want to get poked, prodded, get $15,000 worth of tests, get a procedure that hurts like hell, but you will not ask this man to have a semen analysis. That's the first thing. And then a lot of Black men are suffering from what I call Dorito dick. Okay? And what that means is these men are young. They're 22, 23, 24. They cannot maintain an erection. And these women are having difficult times getting pregnant. Also, we see, because it's like marijuana, they always told us we could smoke weed. Weed is healthy. Weed will drop your sperm count to 0. And these people have chain smokers. And then it ain't like, back in the day when you were smoking reefer. Like I say, if your weed man is less than 60, you smoking some crazy stuff. Now the old people, they smoke the reefer, but now they got
everything in it.
Right. Formaldehyde, fentanyl, all kinds of stuff in it. That even if he has a sperm count, the quality of his sperm is awful. The motility is even worse, meaning they ain't swimming upstream like the salmon. And then the sperm itself is flicted, or they don't have enough of it. So are you seeing this, and are couples being accepting of what you're saying, and when the male makes those changes or sees a urologist, because that's one of my big pushes. Does he see a urologist? He got a whole penis and 2 testicles hanging from his body, and he don't see the specialist? Like, what's going on? So that's one of my big pushes. What are you seeing with respect to male infertility, and especially Black women and Black men? How are they dealing with it?
Yes, thank you for bringing that up. So the first thing we know is that male and female infertility is equal. So when we see a couple where there is a male and female partner, we have to evaluate both of them from the beginning. It's about, when you have a couple, it can be 40% female factors, it can be 40% male factors, it can be a combination of both. So we never want to just say infertility is a female thing, let's do all your testing, and if we don't find anything, then we'll test the male. We're not going to do that. That's insufficient. But again, so much culture goes into just the Black fertility journey for men and women. And I see Black men who are not comfortable. So to do a semen analysis, we say, we're going to give you a specimen cup, and we want you to masturbate into this cup and collect that semen and bring it to the office. And that is offensive to some men. Some men, I don't do that. I don't know how to masturbate. I've never done that. How am I going to get the sample in the cup? I'm not comfortable to do that. We allow them to collect their sample at home. You can be more comfortable than doing that in the office. But that's the first hurdle, is just getting
them to get tested,
to do the testing. And I think that the hurdle for some men is, what if I present this sample, and you tell me something's wrong with it?
Exactly.
What does that say about me? So they're putting up a defense that I don't want to do that, because they're concerned about what that result will say. Again, it's a medical diagnosis if it's abnormal, but they take it personally and feel like, if you come back and tell me that my sperm count is low, then what are you saying about me?
I'm not a man. Right.
So they resist it and they fight. I have seen so many couples that the female goes through so much testing, and the male partner is resistant. And then when we finally test, sometimes we find that he has 0 sperm count or low, or there's been a factor with his side the whole time. So we have to, I don't do any treatment until I evaluate both. And if there's a standoff, I say, well, we're done. This is an incomplete evaluation. I cannot even make a treatment plan for you until I know the status of your partner. So we have to do that part. And again, like you said, women go through x-rays and invasive procedures and uncomfortable blood draws and different things. And we just need you to ejaculate in this cup.
That's it.
Bring it on in. We need you to do that.
Yeah.
Please.
That's a thing. Let's talk about, I really do want to touch on the marijuana thing, because so many, I can't even say it's a huge part of our race. No, it's a huge part of culture. It's
the culture.
Right? It's a huge part of culture. And you have so many females as well, but you have so many males that are chain smoking and chain smoking and chain smoking. And then in the face of infertility, what is the counseling? Like, is there a quantity that they can and can't smoke? And is it a time frame if we know that they have a low sperm count and it may be because of weed? Is there a time frame that they have to stop smoking? Like, tell us a little bit about, because a lot of you women out there are in positions with males who don't feel like they ever gonna stop smoking because it's healthy for them, but you want to have a baby. So how does that work out?
I'm just so bothered by the culture in general of how acceptable it is to smoke and to vape and to just use substances that are just not healthy for us. And you see the young people doing it. You go to a concert, as soon as the lights go down, the whole stadium is full of smoke.
Oh, Jesus.
I mean, I went to a show and I was like, I got a headache. I have to leave the show because y'all are in here just getting it. And so it's just so pervasive and so accepted now that it's a battle for us.
Yeah.
But part of a screening of a couple, we always ask, do you drink alcohol? How much? Do you smoke cigarettes? Do you vape? Do you use other drugs and things like that? We have the most information about tobacco exposure, not as much, real good scientific studies about marijuana exposure. But like you said, other drugs are just mixed with other things now that are just not good to put in the system. And so we always counsel that, especially smoking, tobacco smoking and secondhand smoke can affect male and female fertility. So couples who smoke, or if you go to the hookah lounges and your cigar bars and things like that, that exposure can accelerate the aging of the ovaries, and it can definitely affect the sperm. So we say if you smoke, you need to stop doing that for your reproductive health, as well as your heart and your lungs and everything else. If men make lifestyle changes, the sperm cycle is like 2 or 3 months from an immature spermatocyte to a fully functioning sperm. So if you stop smoking today, you're not going to see those effects immediately. 3 months. So we usually say make your lifestyle changes and then repeat your semen analysis in 2 or 3 months, and we'll see if we can see an improvement after that.
So one thing I want to just circle back that you said, because it drives me crazy. I can't stand this hookah thing. And the reason I don't like it is because it's dumb. And if you're offended by that, I'm sorry. It's just dumb. You're not getting high, right? So you're not getting high. You're literally just taking in smoke and then blowing it out. That is stupid to me. If you're going to do it and get high, that's one thing. And it's like, why do people start doing it? I think they see it in the Middle East and they think it's cool. But that's different. That's like hashish. They're actually getting high, by the way. They do it in private areas and blah, 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 blah. But it's just stupid. And so what she said is when you hookah and you're getting nothing out of it, you're actually aging your ovaries. So for the ladies who think it's cute, they fly, I want to have a baby by the time I'm 32 and Okay, keep with the hookah every Thursday, Friday, and Saturday night. See what happens. All right, just putting that out there.
Right.
Okay.
So we just got to stop doing those things. Just healthy lifestyle. We should just focus on just taking care of our bodies and our mind and being in shape for pregnancy whenever we're ready.
I think, in all the shows that we've done, when it comes to health issues, it comes to chronic issues, it comes to infertility, we keep getting back to the same thing. And I think the most empowering, the most Afrocentric, the most natural thing that we can actually do is live a healthy life and eat healthy food and be good to our body if we want it to be good to us. It keeps circling back. This is not a what do you call it? This is not a whatever, a message that I'm trying to push. It's not. It's what it is. And we need to get back to that.
I think it's not new. I mean, I have a book. I love Dick Gregory. And one of his books he came out with in the early 70s was called Cooking with Mother Nature. And he was preaching the same things that we're talking about now. Fresh fruits and vegetables, whole foods. He fasted until, he was very, very thin. So we don't need to do that.
Right.
But just whole foods and just focusing on the quality. He said, we pay more attention to the fuel that we put in our car than the fuel that we put in our body. And that doesn't make any sense. We need to take care of this machine. It's the only one we got.
I love it.
And so we have to focus on just lifestyle. I'm a big proponent of that.
I think for the culture, that needs to be the new thing. That needs to be the new thing that we do. Not the booties, and no offense to anybody, not the quick fixes, not the this, not the that. The new thing to do, the new it thing needs to be the fitness stuff. Get out there and walk. You can't run, walk. You can't walk, get in the pool. You can't get in the pool, lift a weight. Do something that's going to improve or better this thing that you call a body. You only get one.
Absolutely.
That's why I tell people, if you got one pair of shoes your whole life, you would wear them when they needed to be worn. You would put them up. You would preserve them. You would protect them. Absolutely. You would keep them clean. You would do everything you need to do if you only got one pair of shoes. But you get one body, and we defile it as many ways as we can. Right. Destroy it, and then say, so now what you going to do for me? Because once you've done all that for years, that's when you need it to show up for you, and it doesn't.
Right.
So anyway, I'm hoping that's getting through, that the new thing should be a new thing, and that's just living well.
Right.
You'll look better, your skin will be better, your weight will be better, your mindset will be better, just living well. All right, so now this is what these ladies are always asking when they come in the office.
Yes.
Is there a test? And I know what I say, but I want them to hear from you. Is there a test that can tell me? I'm not ready to have a baby. I'm only 24, but I'm probably ain't gonna have a baby till I'm old when I'm 29. That's what they say. When I'm old, when I'm 29, I want to have a baby. So at 24, I really don't. But is there a test that can tell me whether I can have a baby or not?
So we don't really have a test that says, can I have a baby? However, there are tests to just see what your fertility status is, what your fertility potential is. The first thing that we have to think about for ladies is their age. So you're never too young to think about your fertility. The first thing we can do, like you mentioned, is just living a healthy lifestyle. But that also means reducing your risk of fertility damaging things like pelvic infections, sexually transmitted diseases that can block your tubes, fibroids that can get in the way. So these are things that we can be proactive about, even if we're not ready to be pregnant, because that can impact us down the line.
Okay.
There are tests to check your egg reserve. So for ladies, we're born with all of our eggs. Totally different than men. For men, if their testicles active, they make fresh sperm from scratch every 2 or 3 months. Look at your face.
Adam did us dirty. Eve did us worse. Lord have mercy.
They make fresh sperm every couple months until they're 50, 60, 70. That's why when we see men who are 65 with a baby, we're not even surprised.
Right.
Because they have fresh sperm and they're fertile. We don't see 65-year-old ladies because we have more eggs before we are born. When we're 20 weeks pregnant, halfway through pregnancy, we have 6 or 7 million eggs in our little fetal ovaries. And then by the time we're born, we have 1 million left, which means for all of us, it is a natural process that we lose 4, 5, 6 million eggs while we're still in the uterus, just die off. And then we're born with that million, which is still a lot. We don't replenish it. So from birth, with 1 million eggs, we are drifting down in our egg count from the time we are born. And so our age matters. It's slow, but by the 30s, starts to accelerate. By the 40s, the curve is really getting steep. And so, like I said, it's never too young to think about that. Even if you're in your 20s, think about, being healthy to preserve your fertility. But then you can just get a test. There's a hormone called AMH, which stands for anti-Mullerian hormone. It's a blood test. You can draw any day in your cycle. That AMH is produced by the ovaries. And when your ovaries are active and follicles are growing, then your AMH level is going to be between 1 to 4. As our egg count goes down, the ovaries produce less of that. And when your AMH drops less than 1, that means your ovaries are really slowing down. So you can just say, get a snapshot when you're in for your checkup. What's my AMH level? Is it in the normal range? When you're ready to be pregnant, you can have ultrasounds to make sure your uterus is normal, no fibroids. And HSG is an X-ray to just flush your tubes and make sure that the fallopian tubes are open, no scar tissue, blockage, or things like that. So those are basic things that a woman can do just as a kind of a baseline. What is my fertility status right now?
Okay. So I love it. You heard it's a blood test to kind of check, stop doing stuff that's going to jack up your fertility. You want to know, but then refuse to wear a condom. You want to know, but, refuse to do all the things, and you stay at the wing place all the time. Yeah, we're not going to do that. Okay. So that is, it is what it is. So let's say I'm somebody who's saying, I'm trying to live my healthiest life. I'm trying to do the things. I don't really have any problems. Is there any supplements that I can take to get in front of this? Can I add to my regular multivitamin? Y'all know how I feel about vitamin D. Regular multivitamin, my vitamin D. Is there a supplement or an herb or something that I can add that if it's in my system, if it's built up, I've been taking it for years, that I can help myself?
No.
Okay. I like that. I love that. She's like, no.
We can take vitamins and things. So we do recommend like CoQ10.
Okay.
Or ubiquinol is an antioxidant that can help. There's oxidative stress that just destroys all the cells or damages the cells in our body. Okay. And so the free radicals in your system can just affect cells and how they function. That can affect the ovaries also. So CoQ10 is an antioxidant that you can take in addition to your multivitamin just to reverse some of that oxidative stress that's on your cells. So recommend that one. Okay. But, a lot of times we're looking for just a magic pill that's going to preserve our fertility, increase our eggs, or just change, and we don't have that. So again, it gets back to just, this is the one body and temple that we have. We have to protect it, take care of it by being healthy, take your supplements, and just kind of reduce those other kind of high-risk behaviors.
Okay, I love that. I love that for us. That is absolutely wonderful. Okay, so, all right. So now I want to talk about a couple of things, because I always, starting at about age 25, when my patients come in for their annual, this is what we talk about. I'm like, so because you have a uterus doesn't mean you have to have a baby, but where are we with this baby thing? And I start at 25 and I'm like, well, I don't know. Great. Wonderful. And we talk about, I'm like, have you heard about egg preservation or egg freezing? I call it egg freezing because that's what people are mostly going to know about egg freezing. Preservation, big word. They might not equate one with the other one. So I'm like, have we talked about egg freezing? And I have that discussion once a year. And I'm like, you don't have to do it. You just have to know about it. I always say I don't want the first time my patients to need a thing to be the first time they hear about a thing. Now, if you don't want to do it, you don't have to do it. I don't really care. I'm not vested. I don't have stock in the company. I probably should, but I don't. Now, the point is that, but you're going to hear it so that you'll know. And I tell them I look at it as car insurance. If you have it and don't need it, great. But if you need it and don't have it, that can be problematic. Now, as far as egg freezing is concerned, the process can be rather expensive, but I feel like, and the way I counsel my patients is, it takes your time restraint away.
Yes, it does.
And so what that means is, let's say you do some egg freezing. I'm going to have Doc talk to you all about the procedure and what it actually means. Because I can even learn something, because I'm like, I don't counsel on what I don't do, because I feel like it's not as educational as it should be. But essentially, when you freeze those 27-year-old eggs, they're 27-year-old eggs. So the risk of success is that of a 27-year-old, even if you don't use them until you are 47. It ain't the uterus, unless we got uterine problems, but it ain't the uterus that's the issue. It's the egg that's the issue. We don't know what's going to come up, if breast cancer is going to come up, if another cancer is going to come up, if we're going to be riddled and inundated with fibroids, we're not going to be able to have a baby, and we may not have that. We may have to have a hysterectomy at 36. Now we got 36-year-old eggs versus 27-year-old eggs. So I'm like, if it's possible, because a lot of people's insurance cover, they don't ask. But if it's possible, get those eggs out, get them into a freezer. If you never need them good, you can donate them. They do pay you for them. You can donate them. You can give them to a family member, or you can have them destroyed. But it's better to have them and not need them than need them and not have them. So Doc, that's my counseling. That's as extensive as it gets. I'm like, let me have you go over to Shady Grove. They can talk a little bit more about what y'all need to do. Get your credit together, whether you need care credit, patient file, you got the money on a credit card, your insurance, whatever. But let's start thinking about those things. And if they want to, great. We're going to talk about it every year. You will never say you didn't know, right? So Doc, what is the process? When I send them over to you and they say, okay, I'm all ears, I want to know about egg freezing. How does that work? What is the process?
Yeah, so first, thank you for it's just a quick conversation during their annual, because I don't see all these people, but they see you once a year. And so it's a quick conversation. Are you thinking about it? And if they say no, like you said, move on. But if I was kind of thinking about it, that opens the door. So thank you for just doing that and encouraging them. I see so many women, and I give the kind of talk about what our eggs do from in utero to time we're born. And they're like, this is the first time I'm hearing this. I wish I had heard about this in my 20s and my 30s. So we have to do a better job. Thank you for this conversation about just spreading this information and the awareness about what happens to all of us as a natural process with our fertility. Like I mentioned, the age of our eggs our age is what matters. So when we're born with those eggs, egg count is drifting down from the time we're born, so we're losing eggs. But the other thing is that those eggs are with us the whole time. So as we age, our eggs are aging. And the age of our eggs determines how likely we are to get pregnant and if it's a healthy pregnancy or not. So what we see is that once we're late 30s, over 40, when we do get pregnant, our risk of miscarriage goes up. Our risk of abnormal pregnancies, babies born with Down syndrome and things like that is all directly tied to the age of our eggs. So for women, we always say your fertility, is highest when you're younger. Your best bet is to get pregnant when your eggs are healthier. If you're not ready for that, the next option is to freeze your eggs. And like you mentioned, freeze them at 27. You can come back 10, 15 years later. Your chance of pregnancy is based on the age when you froze your eggs. So that's what you can do. We also do egg freezing we call it oncofertility preservation. So if you've been diagnosed with a cancer and you're going to need treatment to treat your cancer that could potentially damage your fertility, then we can go in and catch your eggs, save them. You go through your cancer treatment, and then once you are cured, you can come back and you can have the healthy eggs to fall back on. When I see women who come in want to freeze their eggs, I talk about the age of the eggs and the whole process. We do basic testing. We do ultrasounds to look at the ovaries and see how many follicles, which are little egg sacs in the ovary, are present. We check an AMH level. We check another hormone called FSH, which tells about the brain communicating with the ovary and if the ovary is responsive and is functioning normally. Once we do that basic testing, we say, okay, we're going to do egg freezing. When women do egg freezing, they are doing exactly the same process as in vitro. It is no different. It's just that with in vitro, once you get the eggs, you continue and fertilize the eggs in the lab and let them grow to embryos. So with the start is the same. The reason that our egg count goes down is because there's not just one egg that develops and ovulates each month. When you have the first day of your period, day 1 of bleeding, there are usually 50 or more microscopic eggs that start to grow in the ovaries. And some of those eggs will grow into follicles. Follicles are teeny little egg sacs in the ovary, and there's an egg inside each one. Then naturally, if you have regular cycles, one follicle grows, and that's your main egg. And that's when it's going to ovulate. Once that main egg is determined, all those 50 plus eggs that cycle just fall back. You lose all those eggs. They just die off. Ovulate your egg. If the egg gets fertilized, then you're pregnant. If we ovulate and that egg does not get fertilized, then you'll have another period start 2 weeks after you ovulate. And with your next cycle, we start over. Brand new 50 plus eggs, some become follicles, one goes all the way. And that's why the count's going down. We go through many eggs, not just the ovulated ones.
Gotcha.
And that happens no matter what. So whether we're in puberty, pregnant, on birth control, breastfeeding, whatever's happening, behind the scenes there's just waves of eggs that start and just fall back in the ovaries every cycle.
So even if you're not having a period,
Even if you're like PCO, I only have one period a year, you still have a wave of follicles that start and then just regress and die off. One of them doesn't go to ovulation, but you're still having eggs
still
that
having
start
those waves.
and regress. They go
so no
through
matter
a
what's
transition.
happening in your life as a woman, every month you got those wave
Eggs
of
are
eggs. So
loose.
not all of them are
Right.
ovulated, but all of them are waving and dying.
They fall back. And so there's nothing that we have that stops that process.
Wow.
Nothing at all. So this is natural for all of us. And it's not the same for every woman, every age, but for all of us over time, with those waves, our egg reserve is drifting down. There's some women whose egg count is higher when they're late 30s, over 40. Some that we'll see that decline at a younger age. But so when we do egg freezing or in vitro, we're just catching a wave. We're just taking advantage of the fact that there are waves that start and fall back every cycle. So these treatments do not increase your egg count, deplete it faster, or change the function of your ovaries in any way. It's just that when we're ready to start your treatment, we're going to give hormones to target the wave that is starting at that point in your cycle. The medicines for egg freezing or in vitro are shots. So when women freeze their eggs, they take daily hormone shots for about 2 weeks. These are self-administered. So we give them medicines and instructions and videos they watch. It's a fine needle, kind of like what you inject insulin with, and they inject it under the skin of their belly or the front part of their thigh.
Okay.
And the average time to do that is roughly 2 weeks, and the purpose of those shots is to target more of those follicles to keep growing than just the natural one. When a woman's taking the shots, we have to monitor the ovaries and make sure the follicles are growing. So for that 2 weeks, she comes to our office every other day. And those visits are early in the day, in the morning. Every visit, she has a vaginal ultrasound to look at the ovaries. At first, follicles are just tiny dots in the ovary. But as the eggs form, the follicles are growing into cysts around the eggs. So we're doing ultrasounds and measuring each follicle in both ovaries. We draw blood every time they come in and check the estrogen and hormone levels. And estrogen goes up as eggs are growing. The normal size for an ovary is like a cherry tomato. It's like 2 or 3 centimeters. When we do in vitro and egg freezing, by the time we're ready to collect those eggs, the ovaries can be the size of an orange or a grapefruit.
Wow.
So women feel kind of heavy and bloated, full. You can still kind of drive and go to work, but you feel your body changing when we do this. So we're just tracking along, looking at the ovaries, and when we see several follicles that are big enough, that's when we say those microscopic eggs inside the follicle should be ready for us to collect. Can't see the eggs, but based on how many days you've been on the shots, how big your follicles are, and what your estrogen level is, we say it should be time. To collect the eggs from the ovaries, we have to put women under anesthesia.
Okay. So y'all don't feel it.
So you're asleep. And we give what's called MAC anesthesia, so it's just IV.
Right.
Nothing, you're not intubated, you don't have
It's
breathing
not general.
tube,
You're
not
breathing for
general.
yourself. No tubes.
Right.
You just
And-
knocked out. Like if you got bad teeth and you go to the dentist. that-
Same. It's the same that you get like Twilight, that you get for a
Twilight,
colonoscopy
yeah.
or something like that. So we put women to sleep, and then we do a vaginal ultrasound, and there's a needle that goes beside the probe. So once they're asleep, put the probe in the vagina, and we're looking at the ovary on the ultrasound screen, and we just center one follicle on the screen. Got a little needle guide that shows the path of the needle, and we pass that needle straight through the vagina into the pelvis and ovary, and we watch it on the ultrasound. Just go into one follicle. The needle's connected to a suction. We step on a suction and drains it, suck the fluid out, and a microscopic egg comes out. And then we back the needle up and go into the next. So we're just draining follicles one at a time, and we're watching ourselves do that. We do both ovaries. The fluid coming out of the follicle is going into test tubes that we're passing off real time to an embryologist who's next door to the OR and a microscope. And we're giving them tubes of follicular fluid, and they're looking under the microscope and identifying and removing the microscopic eggs from that fluid. And they're counting out loud. So when we're doing an egg retrieval, they're saying, I got 1, 2, 3, 4, 5, and we know that we're getting eggs.
Okay.
So all that takes about 30 minutes to do. And then you have a procedure, it's anesthesia, so women have to bring someone with them who can wait in the office while they have the procedure, drive them home.
Wow.
You have to take that day off and the next day to rest and recover. We just take those eggs into the lab. We can look under the microscope and see which of the eggs are healthy, fully formed. We call it mature.
Wow.
And then you just freeze them.
Wow.
If you freeze eggs, they can stay frozen forever. They do
Wow.
not expire or go bad or change. You just lock them in, and then if you choose to use your eggs later, you come back, and then you can work with those eggs. Like I mentioned, if you were doing in vitro, as soon as we extract the eggs, we would have sperm right there from a woman's partner or from a donor. We take the eggs fresh from the ovaries and put the sperm and eggs together in the lab. You put them in an incubator. We monitor as the eggs fertilize and grow into embryos, which is a process over about a week. Then when you have an embryo, you can take that microscopic embryo, pass it through the cervix and put it in the uterus and do a pregnancy test later. You can freeze embryos the same way that you froze the eggs and save them. We can even test an embryo, remove some cells or biopsy it, count the chromosomes, make sure it's healthy, know the sex of it. I take care of couples who might carry sickle cell trait or something like that. Test the embryo to say we want a baby that's not going to be born with a disease that we have a trait for. Can test embryos for that. So if a woman freezes her eggs, we have to be prepared to do that later. So if you freeze your eggs, the next phase to use your eggs, we call it the egg thaw. You have to come back and thaw the eggs out and do that whole in vitro process in the lab. And then you work with the embryos after that.
That you have. Wow. So now let me ask you a question that I always get. So how much rent do I have to pay when my eggs are frozen? Like, what's the rent? What's the rate?
Right. So there's a storage fee for eggs and embryos and things like that. It's right under $1,000 a year of annual storage.
How about I say, damn, $1,000 a month? Jesus Christ.
No.
Okay, so it's about $1,000 a year. That's not
year.
bad. So that's less than $100 a month.
Right.
You can cut out your coffee addiction, which is not good for you anyway, and you can pay for your eggs.
Yes.
Now, I want to hit this from another perspective because this is something that I also talk to my patients about. Again, as African American women, we're now more seeking fertility care, and we're seeing that we have a shortage of African American eggs. So for those women who are in a space of donating or being able to, and I say donate with the hashtag because it's really not donation, but we can't be around here selling body parts, okay? So the point is that we call it egg donation. You do leave with a stipend. And so I'm going to have Doc talk about that a little bit because essentially it's healthy women, stay away from the drugs and alcohol, but it's healthy women who are between a certain age and they're able to donate these eggs. You go through the same process at the end of the process that Doc just talked about. Those eggs don't belong to you. Those are donated to women who may need them, and you leave in a very healthy fashion, after you've gone through the process with the check for your services, for your donation, not necessarily for your body parts and your fluids. So we're going to say for your cooperation with the process, you're paid, you're compensated for your time and not for your eggs. Let's be clear with that.
And pain and suffering. I mean, you're taking off from work or school, you're going through procedures and anesthesia, so
and
you
it
are
ain't
compensated for your pain and suffering and all that you contribute to that process.
Wonderful. Now, Doc, so what is that donation actually, what does that compensation look like? So for these ladies, what is it looking like for one cycle?
Yes, so most clinics are going to offer $7,000 or $8,000 for one cycle of donation. Yes.
Okay.
And so when we recruit, and I see so many women who need an egg donor, and like you mentioned, for Black people, we are at the bottom of every donation list, whether it's our eggs, sperm, bone marrow, blood. Everything. We don't donate our organs, and so the same thing with egg donors. We see fewer. We do have a good participation of Black women who donate their eggs, but we still are underrepresented compared to white women in egg banks and things like that. But women can anonymously donate their eggs. They can be screened by a clinic. We have strict criteria to screen, though. So you have to be healthy, normal weight, non-smoker. You have to pass a drug test. You have to meet with one of our psychologists and pass just a screening to make sure that you are appropriate and ready to donate your eggs to someone else anonymously. We test women, potential donors, for their egg supply with the hormone levels, AMH and FSH. We do ultrasounds and things like that to make sure that they're going to be suitable to go through the process. And we want them to be young and healthy. So 21 to 31 years old is the age range that we are looking for women to donate their eggs. And they donate on a rolling basis. They're anonymous or de-identified. There's no connection between a donor and the recipient now or in the future. These are not matches where we expect couples to find you later, things like that. But it is a selfless gift, because I do see so many women who benefit from donated eggs, and when they are pregnant and they are joyful and they're grateful, and it's a beautiful thing that we can do.
And that's one of the things that I wanted to get out there, because a lot of women don't even realize that's a thing. And if we're not talking to them about it, again, you don't see it until you need it. Right. Or you don't see it until a family member needs it. And maybe you missed the mark. Maybe you're 32. You would have gladly done it. So I like to, especially for my younger women, these are the things that I talk about. These you need to know. If, hey, do it for yourself, and then do it for somebody else. And I had a patient who did it for somebody else so that she could pay to do it for herself. And so it's so many different things in so many different ways, but education is what's paramount. And I feel like as generalists, we don't talk enough about what needs to be said, understood, and heard before you're in the hot seat, or somebody that you love is actually in the hot seat. So I think these things are immensely important. And again, I learn a lot. As I said, I counsel to a point, but I don't want to miss anything and I don't want to fail anybody. So if it's something you want to discuss, I send you off to the people. You got to go talk to the people. I'm going to give you enough to get you interested, or to have you hear me, and then I'm going to have you talk to the people who are really experts at it. And that is Dr. Des. And I appreciate it. You see how calm she is? She's always like this. When you come in for, you just all over the place, I ain't got no baby. This is who you're going to get. She's going to calm you right on down. It's so funny. We were having drinks probably about, I don't know, Des, it had to be about maybe 7 or 8 years ago. And so you remember this? And so we're on a rooftop, and I'm past the childbearing age. I have no kids. It was a choice, kinda. And I'm past the childbearing age. And Des is like, well, we can always pull you out of menopause. Would you like to have a baby? What the hell kind of science fiction voodoo? No ma'am, I'm good. I am great. No, thank you. But yes, it was just as calm. Like, it's just something she does every day. Yeah, we can.
But we do that every day. Our age cutoff is 51. So we can help women and assist all the way up until right at your 51st
Yeah,
birthday.
I remember, because you sent that lady on me. Shout out, girl. Hey, girl.
Yes.
You still keep up with her?
Absolutely.
Yes, that little thing there.
Absolutely.
I love her dearly.
Yes.
Baby, she's so cute. I was literally my oldest patient who delivered. She came to me via Des. I think when we did the delivery,
50.
she was 50.
Right.
And it was so funny. We were, one of my colleagues was like, girl, we did a C-section. She was like, girl, look at this uterus. She said, look at this thing. She looked hysterectomy. She don't need a damn C-section. I said, baby, let's get it done. And it was the most amazing, joyous experience. The patient still comes to me.
Right.
And this little girl runs her whole life. She's like, I'm going to need some soup. I want some soup. How long are you going to be here? I said, well, all right then, little mama.
But it's a beautiful thing.
It's so
when we
beautiful.
can help. And, when pregnancy is high risk. So
Yes.
50 in pregnancy is not easy.
Yes, and getting this lady to stop eating bacon, I almost strangled. I said, eat another piece. I had to talk to her like her mama. I said, one more piece, just one more. I'm gonna put you in the hospital, and you're gonna be on bed rest. You ain't gonna get no bacon.
Right.
One more piece, and you admit it.
I mean, we have a process. We have to screen women.
Yeah,
So
yeah.
45 plus, heart disease, blood pressure, diabetes are risk. So you have to go to see the MFM. We want clearance from that OB. Yes, we are okay for this woman to be pregnant, and we know. And for Black maternal mortality also at any age, that's a risk for us. So we have to make sure that we are, fit for pregnancy and cleared, so that we are already high risk based on our age, but let's manage the other risk factors so that we can get through this pregnancy safely.
Because I said that, and that was a little antidote. I need y'all 55 plus. not to be calling over Desi office saying you need an appointment and you got to get pregnant this month. Don't do it. Don't call this. They don't play that over there anyway. You don't sound right from the gate. You cut off. You cut off.
51.
51. Don't even call it 50 in 10 months because they ain't got an appointment for you.
Right.
But anyway,
as soon as you can.
As soon as you can.
Yes.
Well, guys, I hope this cleared up a lot of myths, a lot of misunderstandings. I hope you got a lot of information that maybe your provider has not extended to you. And maybe this has even changed where you sit in your life and some things that you're planning to do in your life. The goal is to educate you. And the more education you have, the more empowered you are to make appropriate decisions for your life, your body, your partner, everything that's involved. And I hope we provided this. Dr. Desi bust you down like she did the people at the retreat for part 1. And this is part 2. I wanted to get in there with some pointed questions, some roundaway girl questions, some, well, how much it costs? Well, how does it feel? Does it hurt? Do I need somebody to go with me? All the things that you guys definitely want to hear. I wanted to make sure we covered today, and I hope we did that. I thank you so much, Dr. Desi, for tolerating us and coming out again, talking to the girls.
It's all good.
So yes, I appreciate you immensely.
I appreciate you.
Like I said, everybody is not, every skin, all your skin folk ain't your kin folk, and everybody is not vested in you having, I hate to say it, but not vested in you having a good outcome with your, fertility journeys. And this is why I trust Desi and I trust Shady Grove. And that's where I send my patients. So if you're in the midst of that journey, look them up. Y'all don't flood Dr. Desi books because she don't play by her vacation. She gonna go on her vacations. So,
I'm
but
available.
she's the director over there. She's the boss. So it ain't easy to get on her books. Don't be like, I'm calling because I need to see Dr. Desi. It don't work like that. Okay. But at the end of the day, as an organization, trust that I trust that they are ethical and that they do want to see a positive outcome for you and your journey. So I appreciate you, Doc. I hope this blessed somebody. I hope you learned something, and I hope maybe it alters the way you do things, and maybe you can educate the others around you so that as many women as possible can have the outcome for themselves that they hope. So thanks for joining Dr. Tosha After Dark again. This was thebomb.com as usual. Thanks to my brilliant friend, Dr. Desi. And we are out of here, and thank you so much for joining us. Until next time.
3